Morning, guys. Yeah, so I'm Matt Goodwin. I'm one of the heart surgeons at the U, and that was a great talk, Alex. And I have some history slides, but we'll brush over those. And just kind of we've had transplant programs at the U for a long time, and have been doing standard DCD with our abdominal teams for some time. And in 2021, we started doing thoracoabdominal NRP to really have more access to donors to provide organs for our patients. And so we've been doing it for a couple of years, and having been kind of instrumental in starting the program at the U, I definitely remember the process we went through. You know, we had multiple meetings with physicians throughout our hospital, different ICUs throughout our hospital, and ultimately had a big meeting with our ethics committee at the university, and that's how we got the program started. But if any time you guys have questions, just stop me and we can go through details. But we'll kind of go through what thoracoabdominal NRP and abdominal NRP entails, how we do it, why we do it, and look at some of the national data, and also talk about the other method of doing DCD thoracic transplantation, which is using the ex vivo heart-in-the-box machine or the TransMedics machine. Okay, so I have nothing to disclose other than I've been doing NRP for a few years now, and we'll start with reviewing definitions of death. Some of this may be a repeat of stuff we've done today, but this is a picture of the first heart transplantation in 1967. This was Dr. Christian Bernard in Cape Town, South Africa. This was using a DCD donor. So as Alex mentioned, their brain death legislation was established in the 70s. So the first heart transplantation in the world was done using a DCD donor and a recipient in adjacent operating rooms. And so they didn't have any perfusion techniques at that time. The DCD donor passed away, and they procured the heart and carried it across the hallway into the next operating room and sewed it in, and it worked, which was good. But as Alex mentioned, brain death legislation really came about in the 1970s through work at Harvard and the development of the Uniform Determination of Death Act, and also the dead donor rule. These were kind of key ethical components that came out of this work in the 70s. And the dead donor rule states that any patient cannot be made dead to obtain their organs, and the process of organ procurement can't result in death. So patients need to have clearly defined death before any type of organ procurement process takes place. And so we have basically two definitions of death. This is from our intraweb at the U, but we have brain death and circulatory death, and we still use these definitions today, where brain death is the irreversible cessation of all functions of the entire brain, including the brainstem. And then there's circulatory death, which is the irreversible cessation of all circulatory and respiratory functions. And I always make this point, but our definitions of death haven't changed in 50 plus years. We're still using brain dead and circulatory death based on these early studies in the 70s. And that's how we define donors still to this day, as brain dead or circulatory dead donors, DBD and DCD. A lot of countries and ethical teams and medical teams have really started to reevaluate how we define death. And what's emerged is really there's a unifying concept to death, and there's kind of one global definition that applies to circulatory death and brain dead patients. But kind of the unifying concepts of death is that there's an absence of all brain function, including the brainstem, and there's no meaningful blood flow to the brain. So when we do brain dead testing on patients, we do a clinical exam, physicians do their exam, and then there's some additional testing people can do based on your policies, whether it's apnea testing or imaging, that basically shows no blood flow to the brain is what a lot of these confirmatory tests show in brain dead testing. This was a paper that came out last year in Canada, but they've really I would say, done a good job at kind of looking at death and trying to redefine death in more modern times. But they released this position statement as their country has started to really kind of investigate and do more DCD organ procurement. And so they were very stepwise in their methods and redefining death, and then implementing their different NRP DCD protocols in Canada. But I think this paper really captures well what kind of death definitions mean today, and it's really the absence of all brain function, and it will not resume spontaneously, and it will not be restored through any intervention, or any organ procurement method cannot restore brain function. And that's what they've used in Canada, and other countries are adopting this definition as well. And it really ties into DCD on how we think about perfusing organs inside the body, outside the body, and what interventions we do to make sure these organs are going to be really great organs for recipients. So who are the DCD donors? There's these different Maastricht categories for DCD donors, and it's controlled and uncontrolled scenarios. So here in the United States, we use all Category 3 DCD donors, meaning these are controlled DCD donors where they've had devastating injuries, and there's a decision that's made between the care team, the family, the decision makers for these patients to withdraw life support or withdraw care. And that decision is made jointly for a couple reasons. One, the patient is unlikely to survive their injuries, or they're unlikely to have a quality of life that's suitable to those patients. And so there's a decision that's made, like I said, by the care team to start discussing end-of-life care, withdrawal of care. And I think this was covered earlier, but these are the clinical triggers we use to kind of identify patients at high risk of not meeting those quality metrics for them. And these are clinical triggers we use to alert Donor Connect and the OPO on patients that are maybe nearing the end of life. This is a look at DCD transplant growth. This includes all organs in the United States from 2010 to 2022, but the top blue line is all deceased donors in the United States. You can see the uptrend. And then the green line is brain dead donors in the United States. And the orange line at the bottom is DCD. And as Alex showed, DCD growth has been quite rapid in the United States over the last decade. So kind of to get into the specifics of how we do thoracic transplantation for DCD donors, there's a couple different methods. And so these methods have been around for about a decade. DCD thoracic transplantation really started around 2014 out of Australia and the United Kingdom. There were two kind of big centers, one in Australia, one in the UK, that started thoracic DCD transplantation using NRP and an ex vivo perfusion method, which is similar to TransMedics today. But the different methods are direct procurement and transplantation. That's how the first heart transplantation was done. That's how a lot of traditional abdominal DCD procurements have been, where a patient is taken to the operating room after withdrawal of care. Withdrawal of care can happen in the ICU. It can happen in an anesthesia recovery unit. It can happen in an operating room. What's important to note is that the withdrawal of life-sustaining treatment or the withdrawal of care is done by the primary team or the medical team or the ICU team that's been caring for that patient. And it's the same type of end-of-life care you would give any patient in an ICU that's made the decision to have care withdrawn. And so the physicians caring for that patient give all the same types of medications, end-of-life support that you would give any patient in a withdrawal situation. But after withdrawal of care for direct procurement and transplantation, after the declaration of death, the abdominal organs would be procured and either put on ice, which we call cold static storage, or put on a perfusion device and then used for transplantation. The way we do heart and lung procurements, you can do traditional DCD procurements for lung, where after a patient dies, the lungs are procured and put on ice and then transplanted. The heart requires perfusion to work, and so there's different ways to do that for DCD heart procurement, but there's DPP, which is direct procurement and machine perfusion. That's the TransMedics device this day and age. So after the withdrawal of care, the patient is declared dead by circulatory criteria. The chest is open, the heart is procured, and then it's placed on this TransMedics device at the bedside, and it will start beating again. It reanimates, and then it can be transported to the recipient hospital. The TransMedics device has allowed us to travel quite a long distance to be able to obtain organs for our recipients. And then the last method for heart procurement is NRP, and there's different types of NRP. There's NRP for the chest, which we call thoracoabdominal NRP, and there's NRP for the abdomen, which we just call abdominal NRP or ANRP. NRP is an in situ perfusion method, and so in these situations, the patients still have the same withdrawal life support. They meet circulatory death criteria, and then they're hooked up to an ECMO device or a cardiopulmonary bypass machine, and we provide perfusion to the organs in situ. And so these are the two methods again, and DPP will use organ care systems similar to what we've been doing for kidneys for a long time with kidney pumps. Ex vivo lung perfusion has been around for over a decade, where after lungs are taken out, they're put on a perfusion device outside the body. They can even be back at your recipient's institution, and then the lungs are perfused to evaluate if they're going to be suitable for transplantation. And then normothermic is abdominal and thoracoabdominal. And so this is kind of the process that happens. There's been a devastating injury. It's usually a neurological injury, and these patients don't meet formal brain dead criteria, but there's, like I said, there's a decision that's made between the care team and the family, or the power of attorney to withdraw care, and they have the same kind of end-of-life care as I mentioned, but eventually they'll enter what we call an agonal phase, where their blood pressure is low or their oxygen saturation is low as they're nearing the end of life. And we define that, it's defined differently across the world, but here we use systolic blood pressure of 80 or O2 saturation less than 80% to kind of define that agonal phase. And that's important for a couple reasons. When we started doing DCD procurements, we had pretty set time frames on how long we'd watch a patient in an agonal phase. So how long can their blood pressure be low? Can their oxygen saturation be low? And know that the organs would still be good organs for the recipients. So we do keep track of that time. Eventually, these patients die, and they have zero pulsatility on their arterial lines or zero pulse pressure. And at that point, we start what's called a standoff period or hands-off period. We wait 5 minutes after all signs of life have stopped, and we observe for any spontaneous cardiac activity, any perfusing beats of the heart. And we wait 5 minutes really based off this study. This was published in the New England Journal a few years ago, but it looked at, this wasn't for organ procurement. It just looked at resumption of spontaneous cardiac activity after the withdrawal of life support. And so this was done in ICUs across Canada and the UK and I think New Zealand. But they had physicians at the bedside, and they had telemetry and arterial lines on all these patients during the withdrawal of life support. And after patients died or met zero pulsatility, they looked for any spontaneous signs of life or perfusing heartbeats. And so they had clinician-reported events and also telemetry and arterial line reported events. And they monitored how long could you see what we call autoresuscitation, meaning how long could a spontaneous heartbeat happen after the withdrawal of life support or after a patient's been declared dead. And so this is the chart of times when they noted some clinician-reported events or telemetry arterial line reported spontaneous heartbeats. And the longest time for an autoresuscitation event in this study was 4 minutes and 22 seconds. And so after that time frame, there was never a sign of any type of spontaneous cardiac activity. And so it's really from this paper where a lot of transplant centers and OPOs have adopted the 5-minute standoff period. And that's really important in DCD. So during that 5 minutes, the ICU team is monitoring for any spontaneous cardiac activity. And if any is observed, the 5 minutes starts over, and we wait to make sure there's no signs of autoresuscitation or cardiac activity. And it's after that 5 minutes where the patient is declared dead, and it meets all circulatory criteria for death at that point, both legally and that's just how transplant centers have adopted the standoff period now. This is hard to see, but after withdrawal of care in the 5-minute standoff period, the patient is declared dead, and it's at that point where transplant teams will start the organ procurement processes. And so depending on the method, whether it's NRP or a transmedic situation, the initial steps are all the same. There's a 5-minute standoff period, a sternotomy is performed. In transmedics procurements, the heart is, the aorta is cross-clamped, cardioplegia is given to arrest the heart's taken out, and then it's put on this device, the transmedics device at the bedside, and the heart will start beating on the device, and then you can transport it to the recipient hospital. In NRP, we'll go through this in detail, but in NRP, after sternotomy, the first thing we do is we clamp all the vessels off the aortic arch, and that's primarily to direct perfusion to the organs we're trying to procure for transplantation. When you read or look at that Canadian paper on death definition, brain cessation or brain function is going to be permanent, or the loss of brain function is permanent and can't be restarted through any intervention. So NRP is meant to perfuse the heart. It's meant to perfuse the abdominal organs. We're not trying to perfuse a brain on someone that's already met circulatory criteria of death. So the first step is always to clamp the arch vessels, and we always call out when that's been done in the operating room, so everyone is aware that that step has taken place. And then we cannulate for NRP, and then start perfusing the heart, start perfusing the lungs, and start perfusing the abdominal organs. Go through this. But this is just a picture of the transmedics device. It's a portable console. It perfuses the heart with oxygenated blood that's taken from the patient, and then the heart will start beating on this device and remains active up until the time of transplantation. This is kind of the steps of NRP we just went through after declaration of death. Clamping all the vessels off the aortic arch. We cannulate using kind of our standard cannulation techniques, and then we'll hook up to an ECMO circuit or cardiopulmonary bypass circuit and start perfusing the heart and abdominal organs. So kind of the next steps after that, we always reintubate these patients when we're trying to procure the heart or lungs, because that'll allow us to eventually wean off the ECMO machine or cardiopulmonary bypass machine. And so one advantage of NRP is when the heart is reanimated and beating again, we can assess it, make sure it's functioning well. We can do different things in the operating room to make sure it's going to be the best heart possible for our recipient. So we can have anesthesia drop a TEE probe and really do a good assessment of the heart off of ECMO. We can float a swan if needed and look at hemodynamics. We look visually in the field and see how the heart is functioning. But in order to wean off ECMO or wean off cardiopulmonary bypass, we have to reintubate the patient and have them on the ventilator in order to wean from the perfusion machine. So there's quite a few advantages to NRP specifically, but it's really that we're providing perfusion to all organs that are open for transplant, both abdominal and thoracic. And so we've seen that with NRP, there's an increased utilization rate of abdominal organs. For kidneys, there's been less primary graft dysfunction or delayed graft dysfunction with kidneys, and just the perfusion of all organs in situ has really been shown to be beneficial for recipients in the quality of organs and that we've been able to procure using NRP. Compared to the heart in a box, it's a lot less expensive. There's a lot of costly disposables that come with the TransMedics device, and so transplant centers and hospitals are always looking at trying to be efficient with our processes and costs, and so NRP is a lot less expensive than using the heart in the box device at this time. And abdominal NRP, kind of on the other hand, is a perfusion technique where we're just providing perfusion to the abdominal organs. And so these are patients where usually the heart is not in play for transplantation or procurement. You can still get the lungs from doing abdominal NRP, but abdominal NRP can be done many different ways, but the principles are still the same. It's withdrawal life support, standoff period, patient meets circulatory criteria for death, and then we cannulate either directly in the abdomen or we cannulate the femoral vessels. Before starting the perfusion machine, we have to prevent blood flow from going back to the heart or back to the brain. And so we either clamp the aorta directly or use an occlusion balloon. And there's different ways of making sure that there is no perfusion or flow going past whatever device we've used to occlude the aorta. And so we check that for all abdominal NRP cases to make sure that once the machine has started perfusing the organs, we're just providing perfusion to the abdominal organs that we are interested in using for recipients. But using abdominal NRP, we can procure all the same abdominal organs we would use for brain dead donors or traditional DCD owners, and that's been shown to be quite beneficial for recipients as well. So this is some data from UNOS that we're publishing at the U, but this is a look at total brain dead donors and DCD donors monthly in the United States. So it's hard to see, but maybe it's easier for you guys, but it starts in 2019. So in the United States, thoracic transplantation using DCD donors really started in 2019. There were 4 hospitals involved in the TransMedics FDA trial. So when we started DCD in this country for thoracic transplantation, it was just the TransMedics device in 2019. Since then, we've seen a lot of growth in NRP and DPP. So this is looking at just DCD thoracic transplantations. This is just heart transplantations in the United States. And so you can see back in 2019, which is the very first column, all DCD heart transplants were blue, which is the TransMedics device here in the United States. And over the last few years, there's been almost exponential growth in heart transplantation using DCD donors. And the yellow or the orange is NRP. And NRP is not quite half each month, but it's been increasing each month for our DCD heart transplants. This is off the UNOS website, but using NRP and TransMedics DPP, we've seen significant growth in heart transplantation in the United States. So in 2022, there was a 68% increase in just DCD heart transplants alone. And I think, I always say this, but this, I think, has been the most significant growth of heart transplantation in the United States since modern immunosuppression, when you look at the numbers. And so it's been quite a significant change and growth phase. So just the numbers, we do about 4,000 heart transplants in the United States every year. Every year there's 8,000 people on the wait list and about 4,000 added each year. And so we don't come close to clearing the wait list. In fact, the numbers almost diverge because our transplant growth does increase every year for heart transplant, but the wait list far outpaces the heart transplants that are being done. And so there's all these campaigns to increase organ donation across the country, and it makes marginal increases in the organs we have available, but when you see the growth that DCD has had and the impact it has, I say that's why I really say it's been the most significant innovation we've had in heart transplant in 50 plus years. So outcomes. This is also data we have that we're getting ready to publish, but we looked at UNOS and we are comparing outcomes, and we're not the first to do this. There's other papers that have been published looking at DCD and DBD outcomes for heart transplant, but overall there's been no difference in survival, both 30-day, 1-year survival between DCD heart transplants and brain dead heart transplants. So survival's been equivalent across all papers that have been published comparing the two donors used for heart transplantation. We looked at propensity score matching, so we matched donors of brain dead donors and DCD donors, and also showed no difference in 1-year survival using DBD hearts or DCD hearts. So the outcomes across all papers that have been published to date show equivalence in survival using DCD hearts and DBD hearts. This is the incorrect graph, but we also compared, I won't even show that, but we compared DPP and we compared NRP outcomes as well, and also showed that there's been no difference in survival between using transmedics and NRP when it comes to heart transplant outcomes in the country, in the United States. So we know it's safe. We know it has a very positive impact for recipients. It's growing. It increases organ utilization for all transplant recipients, and it's going to save a lot of lives in the long run. It's creating a lot of opportunities to kind of have innovative research, kind of bedside to bench. You know, it's been a very positive and growing trend here in the United States. But it's not without question. You know, back to Alex's comments, there were some papers published in 2019, 2020 about heart transplantation and DCD, and you know, when people aren't familiar with the process or the history, it definitely raises some questions, and we've encountered that even within our own program, because we started just doing NRP at the university, and we've now branched to going to other donor hospitals and donor facilities to do NRP. And I think as the community gains more experience and more familiarity with the process, it's definitely helped. But people will always have questions with the new technology or new innovation.